This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV. This Week in Virology, episode 1256, recorded on September 25th, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
We're all back at our normal places. We're not traveling today, Daniel.
Hopefully that's going to mean high quality audio, video, and content.
Content always. Now let's see. The bow tie.
Okay.
Is it poliovirus?
It is. It is. Look at that.
I've seen it before. I saw the colors and the icosahedral sides, and I thought, well, why not?
Yeah, I think it's appropriate for some of our later discussion, which is why I selected it. So we'll make sure we get into it. But let's start with our quotation, Vincent. Are you ready?
Ready.
Okay, I was looking through, I'm always sort of like, what's going to be the most appropriate quotation for the week? I was looking at some quotations by a guy named Dunning, another guy, Kruger. And I came across this fellow, Charles Darwin, who apparently he had the right head that they allowed him to be on the Beagle. Apparently the captain was a big fan of phrenology. I don't know if you're apparently the first naturalist, his nose was not quite right and the head was misshapen as per phrenology. So Charles Darwin, ignorance more frequently begets confidence than does knowledge. It is those who know little, not those who know much, who so positively assert that this or that problem will never be solved by science.
Gosh, Daniel, I didn't realize that the anti-science people have been around for so long.
It's a good reminder, right? The anti-science movement it's been here forever, really. I mean, ever since the birth of let's go check and let's see what's actually true. And there's always been movements of, you don't need to do that. I know what's true.
Right.
So, yeah, remember Galileo? He got into some trouble because he was doing that science stuff.
It's true. Yeah.
And then what was it? Jenner, if you actually vaccinate people, they're all going to turn into cows. And
What is the resistance to science, though? I mean, people are willing to accept many things. So what is it that people just don't understand how science works? Is that part of it?
So I think that's a lot of it. And I think we don't really do a good job at the early levels, right? Like a lot of people, kind of make it through, you're sort of forced to get through elementary school. And unfortunately, I think in elementary school, we don't actually teach what science is.
Right.
We don't teach the scientific method. We teach hypothesis, theory. But basically, I mean, science is pretty straightforward. It's really asking if something is true and then checking. Somehow we turn it into memorization and,
I heard a good definition of science. Maybe it was here on your program. It was science is doing things so you don't fool yourself, something to that effect.
Yeah. Yeah. I mean, I think that's a lot of it. We don't want to be fooled. We want to actually know what the truth is because the truth matters. And it matters in so many ways.
And today we're seeing, Daniel, science being used as a political tool, and therefore people take conclusions made by scientists and misrepresent them. The whole business with acetaminophen and autism is an example of misrepresentation of scientific findings.
Yeah. And again, this is not new, right? I mean, we can go back and see about how, misrepresentation of genetics and certain racial ideas that were, supposedly put in a context of science. We're not. Yeah. So there's a long history, not only of anti-science, but of misuse of science. So, all right. Well, we got a bunch to cover today. Just going to update everyone on screwworm. It's almost here. Maybe there'll be a movie. I don't know if it's going to be a screwworm movie, but we read this in the AP, and a lot of people sent this to my way, including my daughter, right, who was claiming that I didn't get quite the details of the knocking over of the screwworm maggot story in Panama exactly correct. But so being being interested in screwworm, I read in the AP, Mexico boosts control on cattle after new screwworm case found near U.S. border in Nuevo Leon. And Mexico activated emergency controls just this past Monday after detecting a new case of the New World screwworm in cattle in the northern border state of Nuevo Leon, the closest case to the U.S. border since the outbreak began last year. And the animal was found in the town of Sabinas Hidalgo, and it actually come from the Gulf state of Veracruz. I've been down that way. And basically, Washington has suspended imports of Mexican cattle. So concerning, this is getting very close to the U.S. border. All right, Vincent, you and I have a bit to talk about here. I said we would let the 2-day American. What does ACIP stand for? Advisory
Committee for Immunization Practices.
Yes, I always want the A to stand for American, but apparently it's advisory. Right. So this is that group of individuals that discusses, is supposed to be discussing the science, supposed to be discussing what we know, then coming up with recommendations, and then the CDC director goes forward. So there were a few things there that were a bit disturbing, I will say, right? And we gave some context going into this from a CIDRAP, and I'm going to leave in that link as well. So let's kind of hit a few of the things that they discussed. So MMRV, measles, mumps, rubella, and
varicella.
Varicella, yes. Even my daughter and several others were entertained that I said vaccinia, that I confused varicella and vaccinia. And, yes, I am aware vaccinia is that large, complex, enveloped virus belonging to the poxvirus family used to eradicate smallpox and is actually quite different than the chickenpox virus. But there was a lot of discussion there that maybe we'll just talk about the fact that so really there have been two choices in the U.S. You can get MMR, and then you can get the chickenpox vaccine separate, and that's 85%. That's what most people are doing. You also could decide. You actually had the freedom to decide, or that freedom is about to go away, we hear. You could go ahead and get the chickenpox as part of that, so an MMRV all-in-one vaccine. And what's been discussed, for years past is you may not want to make that decision because there is an increase. It's like a 1 in 2,000, 1 in 4,000, sort of that range of having a fever and then having a febrile seizure. Frightening, disturbing, no particular harm has ever been. But somehow that was revisited, and we heard, basically from ACIP that they were recommending that MMRV not be an option anymore and that the two vaccines be given separately. The next, hepatitis B. And I'm hoping, Vincent, you and I can have a pretty good discussion about this issue, because fortunately, a vote on this was delayed. But they talked about, we have this practice in the United States of giving hepatitis B vaccine at birth. And if you go and you look at the CDC site, and I'll leave in some link, actually, a buddy of mine, Dr. Poe, out in Everett Clinic in the Northwest, sort of sends me stuff, keeps me updated on things. And this was a link to the CD site where they sort of see what we did with hepatitis vaccine over time, right? So we used to have lots and lots of cases of hepatitis B. And then in 1991, we have universal infant hepatitis B vaccination. Then in 2005, we have universal infant vaccination prior to discharge. And it's not until 2018 that we have this universal infant hepatitis B vaccination within 24 hours of birth. And why did we do that? Why was that instituted? It's because thousands of babies were still getting hepatitis B when they were being born.
From their mothers, right? So their mothers were
and that's what it was. Yeah, it was from the mother. So, right. We don't have a perfect system where every single mom is screened. So there is about 10% of women We don't have the results. We don't know. The result comes back. That 24-hour window has passed, or maybe we never get that result. So we were missing. And thousands of little babies were now ending up going through life with a hepatitis B infection, which would lead to, potentially cancer and cirrhosis and all kinds of other issues. So I do want to point out, and the people on the committee seem to miss this, and it's a little bit disturbing that these people on the committee would not quite understand. Hepatitis B is not just a sexually transmitted virus. Getting hepatitis B from your mom when you're born, it's not sex. That's not sex, guys on the committee. That's being born. And we have the ability, and we did do a great job when we instituted this universal infant hepatitis B vaccine of really dropping down the number of babies, who were born to women with unknown hepatitis B status, potentially getting infected. So fortunately, they pushed that up, but this seems to be one of their things. They want to not do that, which we know the result. The result is what we had before we did this. If you move it to 1 month or you move it to discharge, you're going to end up with thousands. When they had it at discharge, right, when that was instituted, we went from the sort of 5,000 to 10,000 range. We got that down to about 4,000 or 5,000, but still 4,000 to 5,000. And that was doing it at hospital discharge. If you go back where it's, not being done until a month of age, we're back into the many more thousands. So
it's worth pointing out, well, first of all, this is tens of thousands of cases in the 1980s. It's worth pointing out that when babies get infected with hepatitis B virus, they are 90% likely to go on to have chronic infection. That means you don't clear the virus, you don't get rid of it. And then years and years of chronic infection leads to liver cancer. Whereas if you're infected as an adult, you're more likely to clear the virus. So it's essential to prevent kids from getting infected, because you are going to prevent a lot of cases of liver cancer. And that's the key here.
Yeah.
And as you said, they don't seem to know this, or they don't want to know it. And they want to make people think that they are saving babies from an unnecessary vaccination. But that is not the case here. And, Daniel, if they decide to eliminate this, there's going to be an uproar. As you saw already, we have East and West Coast health alliances being formed so that the states can make their own decisions. And that's going to be one that the states are going to do. I just wish more states would make their own health alliances.
Yeah, I think that's where we're headed. I mean, this hepatitis B is a great discussion because they basically kicked all the adults out of the room. And so, we've tried risk-based hepatitis B vaccination starting in 1982, and hepatitis B, it just kept going up. And then we started to introduce this. We were seeing over 25,000 to 30,000 babies ending up getting chronic lifelong hepatitis B with everything that comes from that. So, they really just have to look at the history. They could even go to their own CDC site now that they're in this committee and look at all the things we've tried. This is like their vaccines. Let's go back to some technology that was introduced in the 50s and call it brand new, right? The attenuated viral vaccines, somehow that's new again, right? And somehow going back to risk-based hepatitis B vaccination, we tried that. And back when we were doing that, over 20,000 babies were ending up with acute hepatitis B.
Yes, and they become adults and they would pass it on to their children.
Exactly.
And you get bigger and bigger numbers. And we have over 350 million people in the world who are infected with Hep B. As far as we know, there are probably way more. And this is unacceptable. It's a lot of liver cancer.
It is a lot of liver cancer. All right. And then what happened with the COVID vaccines? And actually, I think this is worth spending a little bit of time. So there were several votes around the COVID vaccines. And one, so they've got this fellow who's in charge of sort of presenting and coming up with what we should vote on. And fortunately, I will say one of the things that this individual wanted, put up as a question, is we should require a prescription before anyone is allowed to get a COVID vaccine. And this was across the board. This wasn't if you're under 50. This was you could walk in, you could be 80 years old, you could have a kidney transplant, you could have heart failure, chronic lung disease. The motion was everyone should be required to have a prescription. Otherwise, you can't get a COVID vaccine. Unfortunately, the group basically said, no, that's a bridge way too far. Interesting, not recommending it for anyone. They did not recommend it for even that person that I point out, like over 65, over 75, immunocompromised, multiple comorbidities. They did not recommend it for anyone.
So there's no recommendation for who should get it?
They basically said, you should talk to your doctor. They passed the buck. Not only did they pass the buck, but they're actually, trying to put it in an impediment way. You got to talk to your doctor. That was and that's why we're seeing all these states. We're seeing people jump in, the states jump in and say, no. If you want your COVID vaccine, we're not going to restrict access. We're not going to require you to see a medical provider first.
Just Daniel. All right, two things. First of all they have to do is watch This Week in Virology Clinical Update. They can see you, their doctor, and you can tell them to get COVID vaccines, right?
Yeah, and I am, this is great. I am making a universal recommendation. I think we've talked, and I'm in line with the prior CDC recommendations, which are really parallel that of influenza. Everyone 6 months of age and older, it is a wiser choice to get a COVID vaccine than it is to not get a COVID vaccine.
Has there ever been any other vaccine where you need a prescription to get it?
Interesting. We did have that issue for a while with the shingles vaccine, right? I remember the early days, you have to get your doc to give you but no, it's as far as these routine vaccines, as far as getting a flu shot, no, you just go to the pharmacy. Sometimes like you're at the airport and some, person's, would you like your flu shot? And they just give you a shot right there.
So if you wanted a yellow fever vaccine, would you need a prescription?
So there are only specific providers that can actually give you the yellow fever vaccine. So that isn't like one where you just go to a pharmacy. And that is, it's a little more complicated. You need to look at, are you over the age of 50? That's where we start to see some issues. So there's more of a risk associated with that vaccine.
And why are they messing with COVID vaccines? Do they think there's a problem with them or what?
So I think they were in this now I'm speculating, but I'm speculating with some knowledge here, is they don't want to go out and recommend COVID vaccines because a lot of them come from sort of this group that is anti-COVID vaccines. RFK Jr. has said this has killed more people than any other vaccine in history, none of this being true. So this sort of whole group is in this awkward situation of how do they recommend something that they've spent years claiming is killing people. But yet, on the other side, they have to be careful because, as we've talked, this has become political. And a lot of older individuals who want access to that vaccine are voters, are active politically. So if they really make a significant inroad as far as restricting the ability of those individuals to get the COVID vaccine, there's going to be a problem. So they're sort of playing softball with the COVID vaccines. And we know their real agenda, and this will be more clear as we go forward. The real agenda is to get rid of the childhood vaccine schedule and basically get rid of any requirements for childhood vaccines. That's really their main target.
That would be a disaster, don't you think?
So it is a disaster, and we're already headed down that road, right? There's a lot of states where, you already have the ability to just, quote unquote, philosophically object and just opt out, and that's gotten us in a lot of places less than 90%. So you're required to go to school, but all the people around you are not required to vaccinate their children. I was talking to a New Hampshire pediatric group last night, and they're expressing their frustration when they talk to parents about vaccinations, and so basically said, listen, our parents are no longer interested in what should I do for like the health of the community? What should I do? It's like better for all the other children. They only care about their child. And I said, well, that's exactly what you should point out to them. That's how all the other parents feel. They only care about their children too. They don't care about your child. And that's what we're seeing is, unfortunately, not everyone can get that protective immune response. So if we're not all on board, then we're at risk of all these children getting these vaccine preventable diseases. All right, and we'll jump into measles in a moment, but just an update on Ebola. which actually is a vaccine avoidable disease, right?
Mm-hmm.
So we do. We've got vaccines, we've got monoclonal antibodies. They're bringing all that to play. They've got ring vaccination because we have an ongoing Ebola outbreak in the DRC. As of basically, the reporting is up to September 21st. We're up to 57 cases. We've already had 35 deaths. The case fatality rate is 61.4%. So most of the cases are, they're not surviving. They're dying from the Ebola.
They only have in the country, DRC, they only have 2,000 doses of vaccine. It seems to me that that's not very much.
No. And there is a plan to bring, I think it's like 200,000 doses or something, bring a lot more doses in, also to bring the treatment, the monoclonal in. And this is actually, I think, one of the areas where we cut our teeth on monoclonals as far as acute treatment. You really got to get that in promptly within the first couple of days. This isn't a wait 5 or 6 days. It's really got to be that acute treatment. All right, measles. So we have broken the magic number as of September 23rd, over 1,500. So 1,514 confirmed measles cases in the United States. And, we've talked about the fact that there's already been 3 deaths. And what we've also talked about is that even if you survive that acute infection, we know this children, they have an increased risk of death for the next 2 to 3 years. And then we also, because a lot of these kids are unvaccinated, they're at risk of the longer term, sort of that 2 to 7 year going on developing that SSPE, so it's delayed encephalitis. Canada, another 70 new cases added to the list. They're approaching 5,000, so 4,972 measles cases up there in Canada. All right, flu. We've got a little bit going on here with flu. Now, we've tried to keep this right in the front of everyone. And this week, we actually have the MMWR, Influenza-Associated Pediatric Deaths, United States, 2024-2025 influenza season. And in this report, we read that the 2024-2025 influenza season, so last winter season, had the highest number of pediatric deaths reported, 280, since child deaths became nationally notifiable in 2004, except for the 2009-10 influenza, the H1N1 pandemic. About half of the children who died had an underlying medical condition, or flip that around, about half of them had no underlying medical condition. And also as we're seeing less and less kids get vaccinated, we're seeing this right here. 89% of these kids were not fully vaccinated. A little more information, the median age of death was 7 years. These are like little kids. Only 40% of the children who died were treated with influenza antiviral medications. So I think the question that was asked, should all the children in America get a yearly flu vaccine to prevent only 280 deaths? And the answer should be yes. Yes. Okay. RSV, nice update here with the article Clesrovimab for prevention of RSV disease in healthy infants, published in the New England Journal of Medicine. What's nice here is, for some reason, even people that have an issue with vaccines, somehow monoclonals are okay. This is, as people may remember, babies are born, and we can actually give them a monoclonal antibody. Nirsevimab was what we had around last year. Now we have a second drug, Clesrovimab, or Enflosia. And so here we have some data on how effective is Clesrovimab. So in this article, we read that a total of 3,614 infants received an injection. 2,412 got the Clesrovimab, and 1,202 got placebo. They followed them out through day 150 after the injection, and they're going to look at 2 outcomes here. So the first was RSV-associated medically attended lower respiratory infection, right? So needing to go see the doctor because you've got RSV that is severe enough. In the Clesrovimab group, we're showing an efficacy of about 60%. But even more impressive, right? The number one reason why the babies end up in the hospital in the winter is RSV. RSV-associated hospitalization rate, that was an efficacy of 84%. Really impressive.
Good. So you really think that anti-vaxxers are okay with monoclonal therapy?
They seem to be okay with this because it's not a vaccine. You're just giving the babies the antibodies. And we saw this, right? We saw this during COVID, right? So during COVID, we had all these areas where it was anti-vax and everyone was taking ivermectin and hydroxychloroquine and getting monoclonal antibodies. So we set up pop-up clinics when I was, working with UHG all around the place. Florida was a hotbed. They didn't want the vaccines, but they wanted the monoclonals.
I don't get it, Daniel. It doesn't make any sense because they say, I'm not putting anything into my body. And yes, monoclonals are going into your body.
Yeah, I don't know. Because before I thought, well, once they got sick, then suddenly they're like, okay, now I'll come and see you. I remember I had a patient in Colorado and I'm new to Colorado. I was setting up my practice. And so, once a week or something in the paper, I had my little, Alpenglow Medical. And so I had a patient come and interview me. And he's like, oh, I love your credentials. You went to NYU. I see you did super well. All this training and everything. He's like, but I can't come and see you. And I'm like, why can't you? He said, because you advertise in the newspaper. I'm a lawyer. And as a professional, I've been told that you shouldn't do that. I was like, all right, well, I guess so. And it was a few weeks later, I get a call from the ER. And they're like, Mr. Jones, whatever his name was, he's here. And he wants you to come and see him and admit him to the hospital. He's really sick. And I was like, but I saw, Mr. Jones, that's not his real name. I saw Mr. Jones and he said he couldn't see me because I advertised in the newspaper. He said he warned me that you would say that. And what I'm supposed to tell you is Mr. Jones says that he's really, really sick and he doesn't care anymore because he knows you're a good doctor and he wants you to come take care of him. Oh, yes. So I always thought with the monoclonals, I don't want a vaccine, but then they get sick and they're like, oh my gosh, I'm sick. I want the monoclonals. But here we're seeing it's prophylactically. There's something different in people's minds about getting the antibody versus the vaccine.
Would the same idea apply to antivirals? Are they okay with that?
A lot of them are. I mean, it's a mix, right? I mean, they'd rather have their ivermectin and make believe that's an antiviral. It's kind of a question of what they think an antiviral is. But yeah, and a lot of it is, as we've talked about, it's not based on any science. It's not based on any data. It's sort of these... What your tribe is subscribing to.
Doesn't make any sense. But then again, if you're anti-science, anti-vax, you're not going to make any sense.
Yeah, you're anti-information. So, all right. So maybe we had a peak here. Maybe we had a narrow peak to this late summer, early fall COVID
looks
surge.
Like
it looks like it, right?
Yeah,
so maybe we're going to get a little bit of a reprieve before the early winter.
So like a late August, September peak, yeah.
That's what it's looking like. So it looks like it's going down nationally, and it looks like every single area is on the way down here. So fingers crossed that we get a little bit of a break before the holidays. But here in New York, right, we just entered into the high holidays for the Jewish community, right? So Rosh Hashanah and Yom Kippur. And if our listeners are familiar with that, as my dad always says, Daniel, just think of the Hebrew. I'm like, yeah, that's helping me. So Rosh Hashanah, that's the new year, and Yom Kippur, that's the Day of Atonement. So we have 10 days when there's a lot of individuals in that community getting together. Sometimes we see a little bit of a bump resulting in that. So
Daniel, I took the train to Philadelphia on Monday.
Okay.
And I wore a mask. And as I was getting off, a guy looks at me and he goes, oh, I see you have a mask. Did you get your COVID vaccine too?
What did you say?
Yes, of course I did. I don't want to get COVID. I said, what about you? You're not wearing a mask. He said, I was an essential worker during COVID. I had to be out there on the front lines and I never got sick. I said, well, right. You're lucky.
Okay. Well, hopefully you'll stay well.
It's funny. He saw me a bit away, and then I saw him coming towards me just to ask that question.
Okay.
I mean, he wasn't aggressive, or he was just kind of jovial. I was just...
Yeah.
But I said, you should, if you're worried about getting infected, then he said, no, I never got infected, and I was out there all the time. I said, okay.
All right. All right. Well, if he does get infected, we do have some recommendations for the early viral phase, right? Still recommending the early antiviral treatments.
Oh, that's another point. He
Yeah.
said, "Did you ever get COVID?" I said, "Yeah, I did in 2022 at ASTMH." Remember, Daniel?
Oh, yeah. You guys really struck this
And then
conversation.
he said, "How long were you in bed?" I said, "Nothing. I took Paxlovid, so you should do the same thing."
Yeah. Yeah. I mean, it's hard, it's hard when you don't have enough ends to know. But, I had sort of similar experience, right? I was getting ready to go for a run, scratchy throat, tested positive, started Paxlovid. I was, completely symptomatic by the next day. But of course, I milked it for the full week while I revised the entire parasitic diseases volume.
Very good.
Volume 8. So,
Well, I've been in New Hampshire in the last 3 weeks, New Hampshire, Greece, and Philadelphia. I took with me a flu COVID test, rapid test, and a box of Paxlovid. Never had to use either one. So,
fingers crossed.
I wore a mask when I was around a lot of people.
Yeah. I mean, there's why not keep safe? I mean, somehow it's become like okay to get sick. No one likes being sick. Next time you're sick, like take jot down. This is miserable. I don't want to be sick again.
Daniel, I got to say, I tried to sleep on the plane with the mask on, and it just was very difficult. I couldn't sleep.
Oh, that's funny. I sleep like a baby with the doesn't even bother me.
I even bought a fancy mask with a copper insert,
Yeah. Okay. Yeah.
And they said it was comfortable for long flights.
Yeah.
But I couldn't sleep.
All right.
So it was just okay. I was tired.
Yeah. All right. And if you do get onto that second, unfortunately, we are seeing some folks in the hospital get into that inflammatory, that second week. And so still similar recommendations. That's when you think about, is this person a candidate for steroids, anticoagulation? Still within the window, we consider remdesivir. And as we've been saying for a long time, I'm going to skip right to the end here. We got some letters to talk about, but no one is safe until everyone is safe. I just want to say the donations, they've slowed down a little bit, listeners. As I was watching that Visit the Incubator little YouTube thing that you had on there, Vincent, and just to echo that, we do this, you support us. We do this with the kindness of your donations. We don't take ads. We don't rake in the money. We don't charge or anything. So if you want us to keep doing what we're doing, then pause the recording, go to parasiteswithoutborders.com, click on donate. Maybe you can even multitask. You listen and click while you're clicking the donate button. We are in the middle of our American Society of Tropical Medicine and Hygiene, ASTM&H fundraiser. We're hoping to get up to that donation of $20,000, but we're not really heading on track unless we get some generous folks to go and help us out.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Clark writes, as always, ever grateful for your weekly clinical updates. My spouse and I are healthy physicians and heading for the first time to the Palawan Islands of the Philippines later this year for a couple of weeks to well-known tourist destinations. Looking into potential vaccinations for travel, we are considering two of them, Vimkunya for chikungunya and Typhim VI for typhoid fever. We've taken neither before, but can well imagine that your relatively exotic destinations have led to personal experience with both. Are either particularly risky?
Yeah, so they're not actually. We've covered a little bit of the data on the chikungunya vaccine recently, right? Because that's sort of a newer of the options here, newer of the vaccines that you're raising, and so. Yeah, I think getting the chikungunya vaccine makes sense, right? We had sort of the issue about the two out there, and then the viral-like particle one being the one that we're recommending based upon some safety information. Typhoid, you've got two choices there, right? So you've got the oral and the injectable. I say right, but maybe this is news for folks. There's an oral where you actually put it in the fridge and you take it every other day for 4 days, and make sure you're not taking antibiotics because it's actually attenuated. Or you get an injection. You get the injection, probably lasts 1 to 2 years. I get that on a pretty regular basis with the places I travel to. Well tolerated, neither are particularly risky.
Gail writes, a relative tested positive for COVID 7 days ago, but the red line was very faint. After 5 days, she tested again, and it was bright red. After 6 days, it was fainter. A nurse told her that a lot of people test positive after 5 days, but it's due to the viral fragments, so it doesn't mean she's still contagious. Is there any way to know if she's contagious or not? She's been symptom-free since the first day when she just had a sore throat, and she's been fever-free throughout. Also, if she still has a positive test after 10 days, does that affect your answer?
Okay, so this is probably good just sort of reminder to go through what we've seen here. So in general, the vast majority, 85% or more of the transmission occurs within the first 5 days. So that's why we sort of moved to that. If you've tested positive, you look at when the symptoms started, there's sort of that initial day zero, almost like buying us an extra day, but it's the first 5 days. Now, there really isn't a lot of great data on this ability to use the antigen test. And we've talked about people trying to do actual plaque assays, trying to do quantitative PCRs. We had that really interesting study recently where there was monoclonals, and where you basically, it doesn't really impact your PCR, but it does impact your culture positivity. So really, you don't need to make this terribly complicated. I'm not sure you need to keep testing. The first 5 days is when you're the most contagious. We're really not seeing much transmission after the first 5 days.
So you can test in those first 5 days and then don't test anymore, right?
Yeah, once you know you have COVID, you got COVID, and then you really could save those tests for the next bout.
Helen writes, I have hypertension post-COVID. I'm a 69-year-old female, good weight, exercise, normal cholesterol, eat pretty good, blood pressure has always been good, and have hypertension post-COVID infection in May. I have no history of heart disease. Blood pressure has always been good, about 120/80, now 140/90. Is there any hope I can recover, or will I have this the rest of my life? I've started on some BP meds. Is there a place conducting a research study?
Okay, so first I'm gonna little hope here. So unfortunately, we are seeing in individuals where they get COVID, right? So they get infected, they get through the acute phase, and then they have a number of different post acute sequelae of COVID, and one of them can involve the autonomic nervous system, can involve an increase in the relative sympathetic tone. That's a fight or flight versus the parasympathetic, which is that calm feed or breathe side. Most individuals, by a year, this is going to resolve. Certain things we've talked about over time that you can do. One is keep exercising. Also, the active box breathing to try to really bring up that vagal tone. But no, I don't think you have to plan on having hypertension for the rest of your life. And I think, as we mentioned, there are a lot of places doing research studies trying to help people post-COVID. So that's that. We probably should just start leaving in a link to the recover.org website so people can look through and see if there's a study for you.
This hypertension should respond to medication, right?
It also can. I mean, you could always treat this, and sometimes we'll use things like beta blockers because there can be like a tachycardia and a post sort of exercise heart rate recovery delay. So no, this certainly could be treated. It does respond to medicines.
Carrie writes, I'm a pediatric ID physician scientist who loves TWiV. I heard the most recent episode where you discussed SSPE. I ask you to update your statistics after reviewing the attached article. It's much more common than 1 in 10,000. SSPE is indeed a devastating illness. I've seen 3 children die with SSPE. Unfortunately, it will become more common unless we can educate parents about the benefits versus the risks of vaccine.
Yeah, actually, so I made a special, had a little extra time, and I looked at these ahead of time, the link, the article. So thank you, Carrie, for sending this. The article that was sent was this really nice review where they were looking at the incidence of SSPE. And at least in this article, it was actually quite different than the WHO estimate, which is what I used last time. And in this series, they were actually looking at the incidence of SSPE being close to about 1 in 1,000 for the less than 5, and 1 in 600 for the children less than 12. So really kind of disturbing if these estimates are accurate, considering the thousands of measles cases we're seeing in the Americas.
Yep. Carmen writes, love your podcast, longtime listener. This looks to be a great resource. And Carmen sends a link to what's called the Evidence Collective. These are briefs, focused, actionable documents that synthesize critical information on time-sensitive public health topics. And so there's some recent brief here. For example, 919 fact check of the September 2025 ACIP meeting.
Oh, excellent. Thank you for sharing that. That's great.
And Hillary writes, for months, I've been encouraging my brother, who is a kidney recipient from a live donor, to ask his physician if PEMGARDA should be considered for him. He did not reach out to his doctors about this question, but was willing to ask his doctor at his regularly scheduled appointment at the facility that performed the transplant. According to my brother, the doctor at Leahy Clinic told him that they do not provide PEMGARDA as a prophylaxis, but only as a treatment should he get COVID. What should my brother do?
Yeah, Hillary, this is a challenge, right? And I've actually spoken a little with people at, I think it's Inviad or Inviad, probably pronouncing the name of the company wrong, but the company that makes this. And maybe it's like the wrong company made it and they didn't have like the connections or what it was to talk to folks at the different places. But we've talked about the data on PEMGARDA as prophylaxis. It seems like it would make sense, right? The data would support it as a routine thing at these transplant centers. Really kind of frustrating. I'm not sure we have a great solution here. Even in the New York area, there have been issues with access to PEMGARDA for those of us that have tried to look at getting it for patients.
And she writes, P.S. I've enjoyed learning so much about infectious disease and viruses from your podcast, other Microbe TV podcasts, and Professor Racaniello's online virology course. Very grateful.
It's a great course. I've actually taken it myself.
I met many people on my travels who thanked me for the course in addition to the podcast. So it's very nice to hear that people are getting use out of it.
It's a great course.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.